Well, good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. So in this particular video, I'm going to take a bit of a tangent from talking about the Hamilton T1 ventilator specifically and spend a little bit of time just talking about the basic fundamentals of mechanical ventilation. And this is probably going to be a group of videos that's long overdue and will supplement, if not supplant, the prior videos I've done on mechanical ventilation. I think that this is certainly going to be a fruitful discussion, and it is going to help you all contextualize mechanical ventilation in general. So when we begin to interface with a Hamilton T1 ventilator, you're going to see a lot of different settings and modes, and what does all that mean, and what does it mean in context to other mechanical ventilators, and so on and so forth. And unfortunately, there is a real lack of common terminology when it comes to mechanical ventilation because companies tend to have their own names. They tend to have very specific, in many cases, trademark names for different modes and different settings. And even though the names are different, what is actually happening at a physiological level, what the ventilator is actually doing, is remarkably similar among all the ventilators. And so what I want to do is I want to talk about just the broad physiological aspects of mechanical ventilation, some of the broadly applicable terminology, and then we can take the big picture and apply it to what the Hamilton T1 ventilator offers specifically. So hopefully these videos are going to help be a bridge in basic physiology of mechanical ventilation, and then the specific application when it comes to certain ventilator platforms. So with that in mind, the first video I want to do is just a basic overview of just mechanical ventilation in general. So you can see my real high-tech learning environment that we're going to be using. Lovely, right? It's just like my old videos from over a decade ago. So hopefully everybody is good and nostalgic for those. All right, so let's just start with some basic definitions. First of all, what is mechanical ventilation? So mechanical ventilation is any time that we're supporting, assisting, or controlling respiration. And when I talk about respiration, we're talking about external respiration, right? You've got external versus internal respiration. I'm not talking about cellular respiration, internal respiration. I'm talking about external respiration. That is the movement of gases into and out of the respiratory system and the exchange primarily of carbon dioxide and oxygen across the alveolar capillary membrane. That is respiration. So sometimes mechanical ventilators are referred to as respirators for that reason. So it is any time you're going to support, assist, or control respiration. And what we're referencing here, again, is external respiration via application of positive pressure. This is a very important component to mechanical ventilation. This is a way of providing positive pressure, and that concept is going to be very important moving forward through an artificial airway. This is another important component to understanding mechanical ventilation. So fundamentally, we are supporting, assisting, or controlling external respiration by applying positive pressure in a patient that has an artificial airway. So those are the things that need to be met in order to call something mechanical ventilation. All right? This is important because there are lots of physiological implications when it comes to the application of mechanical ventilation. So mechanical ventilation is primarily positive pressure ventilation through an artificial airway. So you have to have the airways isolated to some extent. That could be with an endotracheal tube, that might even be with a supraglottic airway, but there needs to be some sort of artificial airway. And that is an important concept because, as we're going to talk about here in a little bit, the way that we normally breathe is very different. It's in fact a 180 from what happens with mechanical ventilation. Now, this is maybe a bit contrasted to another way of providing respiration, not through positive pressure, but through negative pressure, right? Negative pressure ventilation, and you all may be familiar with the term iron lung. An iron lung is a device that really has fallen out of use for the most part in contemporary times, but it is essentially a chamber that a person is placed in. Their body is placed in a chamber, and then there's a seal around their neck, and then what happens is the chamber pressure is decreased and increased, and that stimulates, or rather simulates, the normal way that we breathe through negative pressure, which is actually, there are a lot less physiological sequelae when it comes to the application of negative pressure ventilation. Unfortunately, it is very cumbersome. It is a very, it requires a lot of resources and a lot of logistics, and there are a lot of limitations when it comes to negative pressure ventilation. Hence the reason we don't really see it being used anymore, versus positive pressure ventilation, aka mechanical ventilation. Mechanical ventilation is a lot more portable, but there are a lot of extra physiological implications and sequelae, complications associated with mechanical ventilation as opposed to something like negative pressure ventilation. All right, so that's what mechanical ventilation is. What are the primary indications for initiating mechanical ventilation on a patient? Well, there are three broad categories of indications. Broadly speaking, they fall into one of three things. One, inability to protect the airway. So this is a patient, for whatever reason, it could be a variety of reasons, is not able to protect their airway. Maybe they have a head injury, right? They have markedly altered mental status. They're not able to manage their secretions. They're not able to swallow. They're not able to keep their tongue out of their airway, right? Maybe we're in the middle of a surgery. We've given them paralytics. They've been given anesthetic agents, and they're unable to protect their airway due to being in a state of surgical anesthesia, right? Maybe there's some sort of significant trauma or burn injury to the airway, whatever the case may be. They can't protect their airway, and we now have to insert an artificial airway into that patient to provide that airway protection. Generally speaking, mechanical ventilation will be required once that artificial airway is placed. The second major indication is respiratory failure. This is where the respiratory system, for whatever reason, fails to meet the metabolic demands of the body. And there are a few different types of respiratory failure, all right? So there's what we call the type 1 respiratory failure, and this is a failure to oxygenate. This is a failure to get oxygen into the respiratory system, across the alveolar capillary membrane, and into the systemic circulatory compartment, where that oxygen then can be delivered to the tissues and you have your cellular respiration. All right, so that's what we call hypoxic respiratory failure, type 1 respiratory failure. Now, how bad does the type 1 respiratory failure have to get before mechanical ventilation is used is probably not something I'm going to talk about here specifically, but there are lots of various guidelines out there as to how hypoxic somebody has to be given what's going on, and I would just point you into the direction of using whatever the guidelines are that you have at your institutions or your services. but that is one type of respiratory failure. The second type of respiratory failure is what we call type 2 or hypercapnic respiratory failure, and this is a failure to eliminate carbon dioxide. So this is a failure to get carbon dioxide out of the blood across the alveolar capillary membranes and then out of the respiratory system, right? So that is hypercapnic. And again, how hypercapnic does somebody have to be before we initiate mechanical ventilation? There are lots of guidelines out there. A lot of them are based on pH, arterial carbon dioxide, and the overall physiological pathophysiological processes that are causing the respiratory failure. And I would just tell you all to reference your institutional guidelines on that. And then the third type of respiratory failure is a mixed. So it is a mixture of both type 1 and type 2. These are patients that the respiratory system is failing to oxygenate and failing to adequately ventilate. All right? So that is the second group of indications, respiratory failure. And then the third group of indications are what we call the clinical course or the predicted clinical course. And this is where the patient is currently protecting their airway and they're not currently experiencing marked respiratory failure, but based on the trends, based on what we understand of the pathophysiology of their specific disease process, there is a reasonable likelihood that in the near future, this patient will deteriorate to the point where one or both of these first two indications happens to be occurring. This is a predicted clinical course, right? So somebody, say, has a head injury. You initially assess them, they're awake, they're oriented, they're protecting their airway, and then 5-10 minutes later, they're becoming disoriented, they're not sure what's going on, they have some amnesia that's developing, they're asking the same question over and over again, and then maybe 5 minutes later, they're very lethargic, they're only responding to tactile stimuli, all right, and then another 5 minutes later, and they're kind of having episodes of apnea, they're snoring, right, they're opening their eyes and they're kind of opening their airway up to painful stimuli, and so you see this trend of, okay, based on the trend, based on my understanding of their disease process, in the near future, the predicted clinical course is that this patient will become so ensconced in their pathophysiological process that they're not going to be able to protect their airway, and they may even develop respiratory failure. And so I'm going to have to place an artificial airway and initiate mechanical ventilation because I'm predicting that in the near future they are going to deteriorate to the point where they will either not be able to protect their airway, they'll develop respiratory failure, or a combination thereof. So broadly speaking, those are the basic indications for mechanical ventilation. All right, so let's talk about the complications. This is a very important topic to consider. So the major complications, a lot of the major complications of mechanical ventilation really stem from what is going on physiologically. So what's going on physiologically has to do with how we normally breathe, all right? So how do we normally breathe? Well, we normally breathe through what's called a negative pressure mechanism. So here you've got the brain. And what you have chemoreceptors. So you have these central chemoreceptors that monitor mainly the pH of the cerebral spinal fluid as it circulates around the brain, right? Which is a good proxy for the overall acid-base balance of the patient. Your primary drive to breathe is based on the pH of the cerebral spinal fluid and of blood in central vessels. That information gets relayed to the brainstem, and you have 4 major respiratory centers in your brainstem. You have 2 respiratory centers in the upper part of the brainstem called the pons, and then you have 2 respiratory centers in the lower part of the brainstem in the medulla oblongata. And those 4 centers kind of feed back into each other Some are inhibitory, some are excitatory. You've got the apneustic, respiratory center, the pneumotaxic respiratory center up a little higher, and then you've got the dorsal and ventral respiratory groups lower, and those four respiratory centers kind of feed back into one another and produce the overall output to muscles. And the primary muscles of breathing are going to include the diaphragm, and then the muscles that help the diaphragm or act as an accessory to the diaphragm, hence the term accessory muscles. So the diaphragm, the abdominal muscles, the intercostal muscles between your ribs, even muscles up in your neck like your sternocleidomastoid muscles all work to assist the diaphragm. And so what happens is motor information comes out, those muscles contract, the diaphragm drops down, and when the diaphragm drops down, the size, the volume of the thoracic cavity increases. And remember Boyle's law. Boyle's law essentially says that when everything else is held constant, mainly temperature, when temperature is held constant, pressure and volume are going to have an inverse relationship. So that is to say that when pressure goes up, volume is going to go down, and then when pressure goes down, volume is going to go up. So what happens here is as the diaphragm drops down and the size of the thoracic cavity increases by the diaphragm dropping down, that is going to produce a negative pressure, or pressure that is negative when compared to atmospheric pressure. All right, it's going to be lower than atmospheric pressure. Okay, and so the pressure is going to decrease when the diaphragm drops, and that is going to cause the volume of the thoracic cavity to increase, and that will draw air into the airways. Air will be drawn in, okay? That is inspiration, all right? And then what happens is when this signal, the stimulus, stops, okay, the diaphragm will relax and the accessory muscles will relax, and that essentially passively occurs, and you'll have passive relaxation, and then you're going to have the elastic recoil. Think of your lungs as kind of like little rubber bands, the lungs and the muscles surrounding the lungs and the connective tissues. There is some natural recoil, some natural elasticity, and the lungs are going to shrink, and the pressure is going to increase, and the volume will decrease, and then you will exhale. So exhalation is primarily a passive process, whereas inhalation is an active process, but it is a negative pressure mechanism. That is to say that the pressure in your thoracic cavity is less than atmospheric pressure during inspiration. And a lot of the complications of mechanical ventilation come from the fact that mechanical ventilation is an inversion of normal respiration, right? So when I place an artificial airway into the patient, so let's just say we're going to insert an endotracheal tube here, and then I attach that patient to a ventilator, I now isolate the respiratory system, and I start applying positive pressure and using positive pressure to inflate the lungs essentially, right? I no longer have a negative pressure inspiratory mechanism. I have inverted the normal mechanisms for breathing. So what does that mean? That means that I have a markedly increased intrathoracic pressure, right? And that is primarily going to put a lot of pressure on the right side of the heart, right? The venous side of the heart, because the venous pressure is already pretty low, right? Normally in a well-hydrated patient, your venous pressure is about 2 to 5 millimeters of mercury. very low, you're putting pressure on that, you're reducing preload, you're reducing blood flow returning to the heart, and there is a propensity for a reduction in blood pressure and cardiac output and overall end organ and tissue perfusion. That is a big complication of mechanical ventilation. So patients who are already having impaired circulatory mechanisms are going to be at a higher risk for complications when it comes to mechanical ventilation. So people who are in severe shock states may not tolerate mechanical ventilation very well, may not tolerate positive pressure ventilation in general. All right, because you are inflating the lungs, right, and you have a loss of the normal protective reflexes like the Herring-Brewer reflex and the stretch receptors, right, there is a risk of overexpanding and putting too much volume into the lungs and causing barotraumas like like pneumothoraces if you have blebs that rupture, of stretching out and causing inflammatory changes, or what we call volutraumas, and that can result in an incredible amount of inflammatory changes in the lungs, and you can actually have acute lung injuries. You can have inflammation in addition to whatever inflammation may be occurring due to the patient's underlying disease process, okay? And so you have these inflammatory changes that can happen, and you are at high risk for that. Infections and aspirations are another problem, right? Just because you have an artificial airway in place doesn't mean that you can't aspirate. Microaspiration in people who are intubated is a thing that happens, right? That's why good oral care is so important in people who have artificial airways in place, to clean the oral cavity out the best we can, to suction, and to try to do what we can to prevent microaspiration, right? Infections are very common, right? Infections are a very common iatrogenic complication of mechanical ventilation, right? Ventilator-associated pneumonias. In addition to that, acid-base derangements are not uncommon because you now, in many cases, are controlling the respiratory pattern of your patient. Because a lot of the mechanical ventilation that we are going to be using, particularly outside of the hospital, are going to be types of mechanical ventilation where we are essentially controlling all or most of the aspects of the respiratory cycle, okay? And so it's very easy to hyperventilate and sometimes hypoventilate patients and cause respiratory acidoses and respiratory alkalosis, all right? Pain and anxiety, very common, right? Placing artificial airways tend to be inherently very inherently painful and anxiety-inducing, and so there is a lot of pain, a lot of anxiety that can be associated with mechanical ventilation. All right. In addition to this, decrease in muscle tone can happen, right? Because essentially the patient may not be using their normal muscles, the diaphragm, the intercostal muscles, the abdominal muscles, the sternocleidomastoid muscles, and other accessory muscles, and so you can get some atrophy of those muscles, and that can make it more difficult for that patient to initiate and maintain their own spontaneous breathing patterns. In the event that you are able to get them into a situation where the ventilator is in a mode that actually allows for the patient to have some choice in what their underlying respiratory pattern happens to be. All right. And there are some other complications, but I think these are some of the major complications. So this is all to say that the initiation of mechanical ventilation is not without substantial complications and should never be taken lightly. We should never put somebody on a ventilator lightly. We should never get into a habit of just putting generic settings in for every patient and just using one paradigm as frequently as we can, because we really are doing an incredible amount of physiological inversion to the patient's underlying physiology when we place artificial airways and initiate mechanical ventilation and then make changes. We need to take that into consideration, and that needs to be kind of forefront on our minds as we get further into talking about managing somebody on a ventilator, be it the Hamilton T1 or some other ventilator. All right, everyone, hopefully you enjoyed this video, and we'll see you in the next one. Thanks a lot.